Welcome to the GOTA virtual conference. Scan the QR code on the left to participate in our silent auction. The silent auction will run from October 1st to October 29th of 2020. Scan the QR code on the right to go to the GOTA online store. Thank you to our 2020 sponsors. Platinum level sponsor, the Shepherd Center. Gold level sponsors, All About Kids Therapy Services in the University of St. Augustine, and silver level sponsor, Hanger Clinic.
Welcome, everybody. Tonight, we are going to hear from Debi Hinerfeld, PhD, OTR, and FAOTA. She's been practicing occupational therapy for 30 years, specializing in pediatrics, both in private practice and in schools. She is certified in sensory integration and comprehensive behavioral interventions for tics, CBIT. She obtained her doctorate in health science with a concentration in healthcare administration and public policy, and is an adjunct professor at Brenau University in Atlanta, Georgia. Debi is an active leader in the American Occupational Therapy Association, currently serving as treasurer of the board of directors. Welcome, and we look forward to hearing the rest of your presentation.
Thank you, Kristen. So I'm going to share my screen now. So that's probably what you're going to see. And I appreciate that introduction. Welcome, everyone. I'm so happy to have an audience. I wasn't sure if I was going to have anybody attending and if I was going to be talking to myself for an hour. But the topic of my talk this evening is comprehensive behavioral intervention for tics, or what is known as CBIT. And it's an emerging practice area for occupational therapy. What I want to talk to you about tonight is essentially what it is that I do when I work with clients who have tic disorders, and I work with children and adults. And so this presentation will summarize how to identify tic disorders, what they are, to give you a better understanding of what tic disorders are, and then how this new treatment approach that is very much in line with occupational therapy practice. And hopefully I'll be tweaking your interest to possibly get certified and do the work that I'm doing. Right now, I'm the only occupational therapist in the state of Georgia doing this work, and I'm very busy. So there's lots of opportunities. Okay, let's see. All right, so the first thing I want to start off with is I want you to get a feeling of what it's like to have Tourette syndrome, or have a tic disorder. So you see this little piggy in these little red boots. If you see the little piggy in the little red boots in my slides, I want you not to look at it. Okay, don't look at the slide. Don't look at the picture of the piggy with the red boots. We'll see how successful you are. Okay, so Tourette syndrome and other tic disorders are neuropsychiatric conditions. So tic disorders are characterized by motor or vocal tics, and tic disorders typically begin in childhood or adolescence, and they persist over time. The diagnosis of tic disorders is usually 3 to 4 times more likely in boys than in girls, but it is common in girls as well. And it's often accompanied by co-occurring conditions. So here is a picture of an iceberg that I use to help describe tics to individuals who are newly diagnosed with either a tic disorder or Tourette syndrome. You'll see that there's a lot more to this iceberg under the water than up on top above the water. If we think about tics being just the tip of the iceberg, you can see how having other conditions, such as though below the waterline, can contribute to tic symptoms, especially if the individual is prone to having tics. In many cases, a person may have one or more of these co-occurring conditions. And you can see there's a variety of them, and often they're very similar to the ones, if you're in pediatric therapy, that you commonly come across when you're treating children. 86% of kids with Tourette's syndrome have at least one co-occurring condition. And in my experience, many of the children I see have multiple conditions that are found below the waterline. So the prevalence of tic disorders is really more than you would think. 12 to 18% of school-aged children have tics, and 1 to 8 per 2,000 children are diagnosed with Tourette's syndrome. 50% of those diagnosed with Tourette's syndrome also have a diagnosis of ADHD, and 50 to 90% have obsessive compulsive behaviors, which means that they display compulsive or obsessive behaviors, and sometimes it's very hard to determine if those behaviors are also tics. Only 30 to 40% of those children go on to develop a diagnostic category of OCD. Individuals with Tourette's syndromes have a much higher prevalence of depression, anxiety, and learning disabilities, particularly in the areas of math and reading. And believe it or not, but 4 to 10% of the world population will be diagnosed with a tic disorder sometime in their lifetime. So I think what's interesting is that in your lifetime, you probably have met people with tics. And what's important to know is that it's more common than you think. And just because someone has a tic doesn't mean that it is a disorder or that it is impacting their function. Some people might have a small movement of their face or a movement of a shoulder or a crick of their neck. But if it doesn't bother them and it's not impacting function, it's not necessarily something that needs to be addressed. So there are 3 diagnostic indicators according to the DSM-5 that result in a diagnosis of tic disorders or Tourette's syndrome. So first, a transient tic disorder occurs when you have either one or multiple motor or vocal tics, and that the tics have been present for less than 1 year since the first time the tic occurred, and the onset is before 18 years of age. A persistent or a chronic motor or vocal tic disorder is a single or multiple motor or vocal tics, but not both, that have waxed and waned over the period of more than 1 year. And again, the onset is before the age of 18. And then there's full-blown Tourette's disorder, which is where an individual experiences multiple motor and 1 or more vocal tics that have been present at some time, not necessarily at the same time, and they wax and wane in frequency and have persisted for longer than 1 year since the first tic onset. And again, the onset is before 18 years of age. So the characteristics of tics, things that you will notice, is that they can be mild, moderate, or severe. The degree of impairment has to do with how much it disrupts daily activities. They tend to be variable. They are less frequent when the individual is calm and focused, and more frequent with heightened emotions such as stress and excitement. They can be triggered by internal and or external factors. So internal factors, things like stress, conflict, external factors, being bullied, or when someone notices a child doing the tic and points it out to them. We know that tics wax and wane, and what that means is that they come and go. So a child or an adult may be experiencing tics pretty significantly for a period of time, either a few days, 1 day, or a week or a month, and then they go away completely. It's usually when they come for therapy that they're not having their tics anymore. That becomes a problem for me. But besides for that, it's semi-voluntary, which means that an individual can suppress their tics briefly. But what I mean by suppressing their tic is that they can hold them in and make them not happen. However, it's very uncomfortable. It's extremely exhausting. And after the person is relaxed and is no longer working to hold those tics in, they come flying out like a volcano. And what we call that is a tic storm or a tic fit. It can also cause pain and discomfort. Tics can also cause pain and discomfort. So many of my clients will come to me because they're having a lot of pain and discomfort in their shoulder or their neck because they're constantly doing their tic. So it may be a head jerk back, and they're doing it so forcefully that the muscles become fatigued and cramped. And then we also know that tics can be socially stigmatizing because they happen in places where the child is usually, or the person is usually out in public, and people ask them about what they're doing and they can't help it, and it's embarrassing for them. So here is a list. Oops, first I need to ask, did anybody look at the pig? You weren't supposed to look at the pig, so don't look at the pig. All right, so characteristics of tics. So motor tics, some examples. They are, a simple motor tic is an abrupt, brief, repetitive, or stereotypic movement versus complex tics, which are orchestrated series of movements which appear purposeful, but they involve multiple muscle groups or body parts. So a complex tic, a simple tic could be something as small as a small turn of the neck or darting of the eyes, whereas a complex tic is where there's multiple tics occurring at the same time. Vocal tics, a simple vocal tic could be a meaningless sound, like an animal sound, to complex tics, which are utterances of words or phrases. Tics are sudden and rapid and non-rhythmic motor movements or vocalizations, and an individual can have various tic symptoms over time, but at any point in time, the tic recurs in a characteristic fashion. So although the tics can include almost any muscle group or a vocalization, certain tic symptoms such as eye blinking or throat clearing are common across patient populations. And tics are generally experienced as involuntary, but can be, again, voluntarily suppressed. So this next slide is going to show you a list of simple and complex motor tics. So you can see on the left side, simple motor tics are things like eye movements or blinking, facial grimaces, a simple head jerk, shoulder shrugs, arm movements, abdominal tensing, and maybe even leg, foot, and toe movements. So we can see that tics can affect the person from head to toe. And then those complex motor tics look like combinations of simple motor tics happening concurrently. They look like dystonic or abnormal postures. Sometimes I've had clients who look like they're having back spasms, and the muscles in their back spasm and cause them to reel backwards or bend, rotating. They can have tic-related compulsive behaviors whereby they may have to touch something a certain number of times or tap a finger a certain number of times, or if they do a tic on one side of the body, they're feeling like they have to do it on the other side the same amount of times. And then you can have groups of simple tics that happen simultaneously. And this is a list of simple and complex vocal tics. So simple vocal tics include things like coughing, throat clearing, sniffing, and animal bird noises. And you can only imagine right now in the era of COVID how stigmatizing the coughing, the throat clearing, and the sniffing is. If you have a tic disorder where you have those kinds of tics, many of my clients have been afraid to go out in public because they're worried that someone is going to blame them for having COVID. So they don't go out. Complex phonic symptoms or vocal symptoms include saying syllables. So for instance, I have a client right now that says duh, duh all the time. They can say words. They may have what we call coprolalia. Coprolalia is the type of Tourette's where an individual says obscene words, and it's typically what we think of when we think of Tourette syndrome. But as you can see from this presentation, it is only one type of tic. And the majority of individuals do not have coprolalia. I believe only about 2% of all individuals with Tourette syndrome actually have coprolalia. And this tic also waxes and wanes. So sometimes it's there and sometimes it's not. Another type of complex vocal tic is echolalia, where the individual repeats words that were said or heard by somebody else. Palalia, which is repeating sentences. Blocking, which appears like stuttering, where the person is not able to get the words out in a smooth fashion. And also disinhibited speech, so just saying whatever comes to mind. So course of tic severity. So typically tics are present in early childhood and the onset is around the age of 7. It peaks in early to mid-teenage years, around 9 to 12 years old, and then decreases in severity in the late teen years and into adulthood. Severe Tourette syndrome is uncommon, with fewer than 10% of cases becoming severe. While the course of tic severity is typical in childhood, it does at times persist in adults. And many of my clients have either been diagnosed as adolescents or teenagers, or when they entered college, and continue to have tics into their 20s. So it's not uncommon for adults to also have a tic disorder and seek help for or treatment for their tics. The etiology of tics is that it is a neuropsychiatric disorder that has neurochemical, neuroanatomical, and genetic foundations. They do not know what causes Tourette syndrome or tic disorders, but they do know that there is an imbalance in neurochemicals such as dopamine, noradrenaline, and serotonin. In terms of the neuroanatomy, they know that there are abnormalities in the basal ganglia, which are deep in the brain and interact strongly with the frontal lobes of the cerebral cortex and are essentially where those inhibitory centers are located. And so with those abnormalities, there is a lack of inhibition, which is why the individual does their tics. And then thirdly, there is a connection to genetics. There's evidence that Tourette syndrome is familial, but not everyone who inherits the genetic vulnerability will express symptoms. There's about a 5 to 15% chance. In my practical experience, many of my clients will report that there are family members, their close family members and distant family members who have had tic disorders or other co-occurring conditions. So let's briefly talk about the treatment of tic disorders, which is why you all are probably here. The treatment depends on the severity and how disruptive the tics are to daily life activities. Some people with tics do really well and their tics do not interfere. And if they're not bothered by their tics and their tics are not interfering with functional activities, there's really no need to address it, especially if it's not bothersome. For severe problems, the initial focus of treatment needs to be on the presence of co-occurring conditions. So sometimes the issues of the tics are not as bad as the underlying conditions such as anxiety, depression, sensory issues, learning disabilities. And so in many times, the underlying condition needs to be treated in tandem in order for the individual to be successful with CBIT. The treatment of tic disorders may also include medication and also behavioral approaches, which is what CBIT is. Unfortunately, there are no known medications that are known to be 100% effective to treat tic disorders. The typical medications that are prescribed for tic disorders include guanfacine or clonidine, and neither one of those drugs are approved by the FDA for tic disorders. They are both high blood pressure medications that have shown to have an effect on decreasing tics. And I'm not really sure why or what the mechanisms are, but many of my clients are on medications such as guanfacine and clonidine. And the reason they're coming to see me is because they would like to be able to manage their tics without being on medication. And so as I go through this presentation, you'll see evidence that CBIT is a good alternative to medication for tic disorders. So comprehensive behavioral intervention for tics, we're going to get into the meat of this presentation now. It is considered the gold standard in the treatment of tic disorders. It's a behavioral intervention that's based on habit reversal training. And what it does is it helps the individual manage their tics. So it's not curing their tic disorder. If they have a tic disorder, they'll always have a tic disorder. But what this does is it helps them control their tics in situations where they don't want their tics to happen, which alleviates a lot of the stress that they have around their tics happening in situations that they don't want them to happen. There was a study done in 2010 by Piacentini and Woods, and that showed in a randomized controlled trial that CBIT was effective in children and adolescents with Tourette syndrome or chronic tic disorders of moderate to greater severity. And children receiving CBIT had a 31% decrease in their total tic scores on the Yale Global Tic Severity Scale, and there was a statistically significant difference between the experimental group that received CBIT and the control group that received supportive therapy and education only. This finding was only slightly less than the decrease in tics caused by effects of antipsychotic medications in children with Tourette disorder in earlier studies. So this was kind of the grand research study that really demonstrated CBIT's effectiveness and made it the gold standard for interventions above medications. So the principles of CBIT is that it's not based on the assumption that tics are bad habits and thus within the child's behavioral control. So many times you've probably heard of a child that may have had a tic disorder and they're in the classroom and they're having a lot of movement, or they might be shouting out or making noises, and the teacher tells them to stop. So we know that tics are involuntary, but that the expression is often influenced by environmental and situational factors. So by telling the child to stop doing their tic in the classroom, it's an antecedent that makes the child feel a heightened emotion of getting into trouble when he cannot control what's going on in his brain, and it causes the tics to happen even more. And then eventually what happens is that child gets in trouble and is asked to leave the room, which causes even more anguish and more ticking. The child in CBIT is taught to be aware of their tics, to be able to interrupt the tics through what we call a competing response. And this is where we talk about habit reversal. So the competing response is something that the person does that's incompatible with their tic, so the tic doesn't happen. So a lot of people will ask, well, if they're not doing their tic, does that mean they're just suppressing their tic? And in actuality, they are not, because they're doing something different. If they were just pushing that tic down and not doing anything but holding it in, that would not be a competing response. But the competing response is something that they're doing something, they're focused on a movement or a competing, or focused on something different than the tic that they're actually doing that makes it impossible for the tic to happen. And they hold that response until the urge to do the response goes away. And then they have to practice that. So we're teaching them habit reversal training or habit training, which we want them to develop that competing behavioral response. We want it to become automatic, so that every time they are about to do their tic, they automatically do their competing response, which we also call strategies or exercises, and it prevents the tic from happening. Okay, so how do you establish a competing response? Okay, so one thing I want to ask you also to do during this presentation is, while I'm talking about this slide, I want you to not blink your eyes. So just keep your eyes open and try not to blink. That's another way to feel what it feels like to suppress a tic. So a competing response is something that's incompatible with the tic. It's something that the individual can hold for 1 minute or until that urge dissipates. And the urge is what the person typically feels before the tic happens. So some people don't feel an urge, but a lot of people feel this sense that it's about to happen. For vocal tics, it's often this feeling of a pressure or a bubble that they need to pop in their throat. Sometimes for a neck snap or a head jerk, it might feel like a muscle needs to be stretched in the back of their neck, or they feel a pressure that they have to pop. And then the competing response also is something that can be done in multiple contexts. So it needs to be something they can do if they're sitting at their desk at school, if they're driving, if they're riding in the car, if they're taking a test. It needs to be done in multiple contexts. And also it should be something that's not any more noticeable than the tic itself. Okay. So the cycle of tics and habit reversal training looks like this. So the individual gets an urge, we call it the premonitory urge, and then they do the tic, and then the brain gets this sense of, relief from the tic. So CBIT is the interruption of the tic as soon as the tic happens, right as soon as the urge is felt and before the tic occurs, so that the relief that's gained from using the competing response is from using the competing response and not from the tic itself. So as you remember me saying in the earlier slide, and how many of you had to blink? So I'm sure many of you have blinked by now, right? And it was very scratchy and itchy and really hard not to do the blink. So that's what it feels like if you have a tic and you can't, and you're holding something back and you can't do it. You're suppressing the ability to blink. So when you're using a competing response, you're successfully interrupting the tic at the point of the urge. And then you hold that incompatible response, that competing response, until the urge goes away. And oftentimes what I hear my clients say is that that urge increases in intensity for a little while, because remember, this is something they have to hold for a minute, because it can take up to a minute for that urge to go away. And then gradually the urge starts to decrease in intensity, and eventually it just fades away. And it's really amazing when that happens, because my clients will look at me and say, oh my gosh, I don't feel like I have to tic anymore. And it's almost a life-changing experience for them, because they have finally established something, or have learned that they have more control over their tics that they never thought they would have before. So the components of CBIT, first of all, we do education about tics and Tourette syndrome. Many of the clients that come to me will have been newly diagnosed and really don't know very much about Tourette syndrome or tic disorders, or even what CBIT is, but they know that their neurologist or their psychiatrist has referred them to someone like myself that does CBIT to help them manage their tics. So it starts off with psychoeducation about tics and Tourette syndrome, and then we start with self-awareness training, which is the core of CBIT, because you cannot implement a strategy if you don't know it's happening, right? So self-awareness, the client needs to describe the tic. They describe what the sensations are or the behaviors that occur right before the tic happens, and they point out when they happen. So what I typically have my clients do is raise a finger to let me know that their tic's about to happen, and then they tic, and I give them positive reinforcement for every time they do that by telling them great job, because I want to know that they're aware that their tics are happening. Some people are not aware that their tics are happening, and we have to work on bringing about that awareness. Then the therapist and the client create a tic hierarchy, or a list of current tics, and we operationally define them. So they may tell me they have a neck shaking tic that's defined as their head moving from midline, moves right and back, and then returns to midline. So what we do is we really define the components of the tic, again, to build awareness about what the tics are, how they feel, what they look like. Then the client rates how bothersome the tics are on a scale of 0 to 10, with 0 being not bothersome at all and 10 being extremely bothersome. And when I talk about concepts of being bothered by their tics, I'm talking about being embarrassed, that it's painful, that it causes them problems when they're reading, that when they're writing with on a piece of paper, that they rip the paper by accident, that they can't drive because their tics, they're constantly throwing their head back and their vision is off of the road. And it bothers them that they can't perform the things that they want and need to do. The treatment is based on the identified tics, beginning with the most bothersome one for the client, and also the one that is most likely to be met with success. So I usually pick a tic that I think that the client is going to easily learn how to use their strategies and manage easily and quickly, so that that helps them become more motivated to work on the ones that may be even harder. The goal is to be successful with managing the tics, and with kids, I call it tic busting. with less distress than from the beginning. So as the person moves through the therapy, each week we rate their tics, and the idea is the more often they're able to bust their tics, the less bothersome that tic is going to be, and the goal is to decrease the rating of distress from a high number to below 2 or 3. All right, so then we, once we decide what our tic hierarchy is, we develop the tic busting strategy, and then the person, the child or the adult, has to practice that over and over, and that includes practicing with a support person. So I usually have a parent or some other person that comes to therapy with the child to learn how to help that person practice their strategies in between sessions, and give them lots of positive reinforcement for when they see them using their exercises or their strategies, and to remind them to use their strategies if they see that they're ticking and they're not remembering to do that. Because again, we're developing a habit, and a habit is only developed if you do it over and over again. The other part of how we approach therapy with CBIT is we do a function-based approach. And so we look at environments and social situations in which we're able to make modifications to prevent antecedents or consequences from happening. So an antecedent for a tic may be that the child is anticipating having to take a test in school, or being bullied, or is very sensitive to noise in the classroom or on the bus. And so we might modify that situation for the child. Maybe we teach them some relaxation strategies to do before they sit down to take their test, or we ask for an accommodation. Maybe that child is given a 504 accommodation to be allowed to take their test in a quiet room by themselves. Or if there's a situation with a bully, we may try to teach that child how to advocate for themselves, to let them know some strategies on how to approach that bully, and teach them about why they have their tics and that they can't help that they have it, and to understand that it is a condition just like a condition for a person that has diabetes or asthma. It's not anything different. We also work on relaxation training. So we know that many of these individuals have underlying coexisting, co-occurring conditions, and anxiety is a common one. So teaching them how to relax, because again, we know tics are often triggered by a heightened emotion. And so if we can get them to calm down and teach them calming relaxation techniques, sometimes that also helps support their success with CBIT. For young kids, we also will implement positive behavior reward programs. So I often have set my younger clients up with strategies or games that they can play with their support person, where they earn points every time they bust their tic. And we come up with the parents ways for them to win or earn a reward, whether that be money or an experience with their parent, maybe going out for ice cream or having a little extra time to stay up on the weekend, those kinds of reinforcements to help them stay motivated. So there's about 8 to 11 sessions in each CBIT in this protocol, and how many times you see the child. And it really depends on the number of tics that the individual wants to work on. But the first session is usually when you're doing your evaluation. You're going to start with psychoeducation about tics. You'll do your assessment, which typically includes an intake form. I use the COSA. We are developing a COSA, a child occupational self-assessment, which is a MOHO evaluation. One of my colleagues that taught me CBIT developed a COSA-T, one for tics, for her doctoral work, and we are working on validation studies for that and reliability studies. We teach them, we give the person homework after the first session to promote self-awareness, and we identify the first strategy. Usually that occurs in about 60 to 90 minutes. Then we have weekly sessions, sessions 2 to 6, and they follow the CBIT intervention protocol, which involves reviewing how well the child or person did on their homework the week before and how successful they were. We again look at their tic hierarchy and teach habit reversal training for the next tic that they have identified as one they want to work on. We continue to do ongoing assessment, and we look at environmental and situational modifications, or we do that functional based approach as well during weeks 2 through 6. Weeks 4 and 5, we add relaxation techniques to the main protocol, and I typically teach them what we call 4 square breathing or deep relaxation breathing and progressive muscle relaxation. Some of the other strategies we give to our clients is we'll often recommend different apps that they can use on their phone, meditation apps, calm music apps. We talk about strategies to promote rest and sleep. Most of the time that's taking the phone out of the person's bedroom at night, because it's very tempting to look at that phone and scroll through that phone and also text their friends till late in the night. And then if sessions 7 and 8 are needed, those occur 2 weeks apart, with session 8 focused on relapse prevention. So teaching the individual what they can do in case they get a new tic and training them to be independent with coming up with their own competing responses or tic busters. And then sessions 9 to 11 are typically booster sessions, and those are really scheduled on an as needed basis. So I don't normally use those sessions. Many times my clients know that if they get into a spot where they come up, they have a new tic that occurs and they can't figure out a competing response, they will always welcome to call me so we can problem solve through that and come up with something that will work for them for that particular tic. So why are OTs great CBIT providers? Well, we know how much tics can have an effect on an individual's participation. In school, as I said earlier, if they have eye tics, they have trouble focusing from the board to their desk. They may lose their place when they're reading. They may have trouble with doing math problems because of eye tics. They have trouble sitting still in their chairs. So it can have a tremendous effect on learning. Of course, we know that having a tic is a stigma, and children may be less inclined to participate in social activities for fear of ridicule by their peers. Self-care and feeding can also be a problem, especially if the individual has a tic where their hand or their arm moves quickly and abruptly. I have had a client that had a really hard time managing their tic while they were brushing their teeth and could not bring the toothbrush to their mouth to be able to brush their teeth. The same thing with feeding. If you have a tic and you are trying to bring your fork to your mouth, there's a chance that that fork could miss your mouth because of your tic and cause injury or just be very frustrating during that process. It can affect leisure and play, particularly like going to the movies. If you have a vocal tic and you want to go to a movie and you're disrupting other patrons' ability to watch the movie, you're probably not going to participate in that activity or be ostracized so that you can't participate in that activity. And then rest and sleep, also very important. Many of my clients will say that they tic at night or they tic right as they're trying to go to sleep. Maybe in some cases, they start ticking at night before they go to sleep because they're worried they won't be able to fall asleep, and it becomes a vicious cycle. So the other reason that OTs are great CBIT providers, not only because we work in these environments or in these situations, but we're also very easily accessible in schools where many children probably have tics that are not even being addressed, or if they are, they're being maybe punished for having their tics because people don't understand what it's all about. We are in primary care, and we also work in neurological clinics with neurologists that are the most likely people to refer to us. We know how to structure opportunities and rehearse skills in appropriate contexts and environments. So we teach people how to modify their activities in different contexts and environments, and we have them practice that until they are proficient. And we're also very familiar with sensory influences on behavior and how that can heighten heighten their behavior or emotions, and we're familiar with how to help them modulate their behavior as well. So tics, how do they impact on participation? So again, these are some of the examples I just gave, completing tasks in the classroom, persisting through completing difficult tasks, again, socialization, fear of ridicule, lost opportunities, sleep and rest, waking up through the night, being tired the next day. Also, being tired can trigger a person's tics. And then ultimately loss of self-esteem and confidence. So again, that function-based intervention is very much in line with the occupational therapy approach. It's determining what events happen right before or immediately after that makes the tics more likely to happen. And we're very good at modifying activities, tasks, and environments to minimize or eliminate those situations that make the tic more likely to happen. Eliminating the situations or events that happen right after the tic happens that reinforces that tic, and using strategies to minimize reactions when entering into situations that cannot be modified. So oftentimes if a parent or someone comforts a child that's having tics, that reinforces the tic subconsciously, and it continues to happen. Or if a child is having a tic while they're watching TV, and the sibling comes and changes the channel, and then the child starts ticking, and then if the child that changed the channel was punished for doing that because it made their brother or sister have their tics, that reinforces the tics too. So we're looking at how do we change those situations? So making sure that the child can't get out of an activity because they're having their tics, but also not excluding them for having their tics either. So helping them deal with those situations as best they can, but making it a little bit easier for them to manage their tics using their strategy and also with that functional-based intervention. So again, a little bit more evidence behind the studies that were done on CBIT and the effectiveness of it. Again, that study in 2010 showed 52.5% of the children who received CBIT showed significant symptom improvement compared to 18.5% of children receiving the control treatment. There was an adult study done in 2012 that showed that 38% of those who received CBIT showed significant improvement in symptoms compared to only 7% who did not receive CBIT. And interestingly enough, both studies showed that the benefits of treatment remained for at least 6 months after the end of the study. So they were sustainable results. And this is another slide that just has a little bit more research that was done. On the first one is the one I have been referring to. The second study was actually done by an occupational therapist. So Jan Rao is an OT at Children's of Alabama, and she was the first occupational therapist to be trained in CBIT. And she's actually who trained me in CBIT. And now she and another individual who was trained by Jan and I have been doing trainings for other occupational therapists up until COVID. Our last 2-day seminar was held in December. And now with COVID and everything going virtual, the three of us are working on developing a virtual platform on which to continue training occupational therapists in this process so that we can get more OTs doing this work because there is such a great need. So Jan did a study that found that CBIT reduced the number of tic expressions, tic severity, and level of distress, and that it associated with tics, and it improved the children's perception of their competence in and importance of performing their everyday activities. And then there was a study done on a chart review that was done, which is this last study that is cited here. And it was a study showing that clients demonstrated a positive treatment outcome even when CBIT was flexibly applied in clinical settings. So while this is a protocol-based approach, there are, There are ways that you can modify it to fit the population that you're working with. So it can be used in a flexible manner. And then hot off the press, so this was just published this year. So Heather Simpson at University of Florida, Jan, Dr. Yoon, and several others did a study on handwriting skills of children with tic disorders. And it showed that children with tic disorders took longer to complete writing tasks and committed more case substitution errors than the normative sample. And that was on the test of handwriting skills revised, and they were likely to exhibit handwriting deficits. So it just goes to show that kids with tic disorders, how much it impacts them in their school performance. And so future directions, where do we want to go in the future? Well, for one, we need to do more CBIT training for occupational therapists. And there is CBIT training specifically from those of us that have been trained, myself, Heather, and Jan, but there are also trainings through the Behavioral Institute at the Tourette Association of America that you can also participate in, although those courses can be a little bit pricier. And right now they're not being held at all because of COVID. Jan is also working on developing a CBIT training manual so that individuals would have an actual manual as occupational therapists to be able to do this approach. And then there are several studies on how we can use CBIT through telehealth. And right now, my entire practice is based in telehealth. So I'm seeing all of my clients virtually, and it's working out quite well. So how can you become a CBIT provider? Well, you can go to the Tourette Association of America. They have trainers and scheduled trainings. It's a 2-day training. And then once you receive that training, you need to have supervision during 3 or more clients, usually by someone else who's already doing this work to finalize your certification. And then after you are mentored and supervised by someone who's already certified, you can get your name on the national list on the Tourette.org website. And also you can market to neurologists, pediatric neurologists, psychologists, psychiatrists, and let them know that you're doing this work. And I promise you, you will get referrals. So I tend to get a lot of referrals at the very beginning of the school year. I got a ton of referrals when COVID happened, when all the children went to virtual learning. And just recently, again, another wave of referrals has occurred because of the kids who are going back to school in person, but having to abide by all the COVID rules. So a lot of stressed out kids out there, and lots of tics happening that these children don't like. They're just experiencing them for the first time. And it's just adding to the stress. So I've had a lot of clients referred to me because of those issues. So here are some more resources that you can look into if you're interested in learning more about tics and tic disorders. And then I'll just open it up for questions.
Thank you, Debbie. One of the things that came to my mind right away is, I know you mentioned that you need to have awareness to be able to go through the steps. What is do you think the youngest patient that you've treated or client that you've treated with this type of intervention?
That's a great question. So personally, I haven't treated a child this young, but some of my colleagues have treated children as young as 4 and 5 years old. So it has to be a child that can develop that awareness. And some kids can, you'd be surprised. But typically the most successful kids that I've had have been the youngest around 7 or 8. But some of my colleagues have worked with kids as young as 4 and 5 years old.
Have you found that age, correlates with how long they're able to keep what you've taught them, or the compensatory measures and things?
Yeah, and it's interesting because I feel like the younger the children are, the better they do. So they're more motivated. It's easier to entice them with rewards and for them to earn things by practicing. As they get older, they're not as motivated. I'm not sure why. Maybe because they have so many other things going on. And of course, they're in that developmental stage where they're not wanting to listen to their parents or, have to practice something all the time. So it does. And it sticks too, because, as I said, tics wax and wane. So as the child is learning how to manage their emotions and be less stressed, and then while they're practicing their competing responses or their tic busters, sometimes the tics will go away and not come back, right? Because they wax and wane. And so then it's not a problem anymore. And just because a child has a tic when they're 6 or 7 doesn't mean they're going to continue having tics for the rest of their life, right? So they may just be having them during that period of time and then they go away. Or you have kids that have tics for a period of time and then they are able to manage those tics and they stop happening because you've trained the brain to do something different. And so the brain's not looking for that original sense of relief from the original tic. And then later on, they may develop a brand new tic or something completely different. And so that usually with the younger kids, they'll come back because they're not old enough to really understand how to create their own competing response. And so they might have a booster session and just learn how to do something new.
And that kind of led into another question that I had, which is, out of the research studies and the references you cited, are any of those longitudinal studies regarding interventions? I know that you mentioned occupational therapy is relatively new to the game, but can you speak to any of longitudinal findings in research?
They haven't. The most length of time that they've gone back and looked is the 6 months. So they have not, but we need to do more research in this area for sure. So that's a possibility, is to look at that. It might be hard though, because of the tics waxing and waning. You know, in terms of longitudinal studies, if the tics go away forever, it's hard to know if the effect was CBIT or if it was that their situation, their life circumstances changed, or I'm not really sure. But right now there haven't been any longitudinal studies that I know of. Are there any other questions?
So if they're not doing training now in terms of in-person following a model and that kind of thing, so nobody new is coming into this treatment, is that correct?
So right now, the number of OTs that have been trained in CBIT across the United States is around 150. And again, our hope is to get a training out sometime in late spring. The 3 of us were planning to do that. And we actually got the Tourette Association of America we got their blessing to do this. Because they do the trainings, but because of COVID, they're not doing them right now. And so, and they do support us in terms of being a really key discipline to carry this out, because they understand how well we do that. And then the other thing is that we can charge CPT codes for this, whereas other disciplines are less likely to, like especially psychology. There's many people trained in this in the area of psychology, but for some reason they don't have the CPT codes to charge insurance or third-party payers, and so they can't get paid for it, and so they're less likely to do it. So there's not a lot of resources out there for people with Tourette's, so the more of us that are able to do it, the more we can serve this population.
Thank you.
Debbie.
Yeah.
Hi, I
Hey.
have a question. I just wanted an example. My name is Pat.
Hey, Pat.
I wanted an example of a way that one of your clients uses to suppress their tic.
So you mean to
Just an
suppress-
example.
You mean to suppress it or to bust it?
Bust it.
Okay. So for instance, I should have included those. So for instance, a competing response. So if you think about like a neck twitch where they're constantly throwing their head back, something that's incompatible with that is to not be able to throw your head back, right?
Yeah.
So one of the strategies that I might teach them is to do a double chin. So pull their chin down and in.
Okay.
And contract all the muscles in their neck and hold it still. just like this.
Uh-huh.
And they would hold it, hold it, hold it until that sensation that they had to do it went away. So that's
Okay.
one competing response. Another one would be for like a blinking tic, right?
Uh-huh.
And so the person's constantly blinking their eyes. So the competing response for a tic such as that would be to hold your eyes open as wide as you can and stare straight ahead and blink very slowly so that you're not scrunching your eyes.
Okay.
So for individuals that might have a hitting tic or a punching tic,
Right.
sometimes what I'll have them do is if they feel it is hold their hands together at midline, just clasp like this. So they're holding them together.
Uh-huh.
If someone has a vocal tic, the vocal tic competing responses are the same regardless of what kind they are. And essentially what that is closing your mouth, holding your lips together, and breathing slowly in and out through your nose.
Breathing. Okay.
So what I often will ask my clients to do is try to write their name on the roof of their mouth while they're doing that with their tongue. And they'll say, but that's impossible. I said, well, just try it. Because oftentimes when they're concentrating on something else that's almost impossible, it takes their mind off what they're doing. And then the urge goes away a lot faster for them. And it's not as uncomfortable.
That's exactly what I was thinking, because meanwhile, while they're doing that, the urge is going away.
Yeah. So, and the urge will intensify while they're holding, especially when they first learn how to do it. It'll intensify and then it'll gradually plateau and then dissipate and then melt like butter. And it's amazing when they let go of their competing response and they're like, oh my gosh, it went away and I didn't tic. And it's like, it really is life-changing. It makes them like, feel like, oh my gosh, I can't believe I can control this.
Oh, I can imagine.
It's really cool. Yeah, it's pretty cool.
Well, those are good examples. And I knew they would be when you told me. I knew there would be some good ways of doing it. Is a cursing, using profanity, is that a common tic?
So like I said, that is what's called coprolalia.
That's the coprolalia one? Okay.
Coprolalia, and it's very rare, actually.
It's very rare? Okay.
Yeah, it's the type of, so out of all the people that have a tic disorder or Tourette syndrome, probably only about 2% of individuals that have a tic disorder actually have coprolalia.
Okay, that's
and
good
again,
to know.
the tics wax and wane too. So they may have coprolalia for a little bit of time and then it goes away. So like I have an individual, a young girl I'm working with right now, and she's struggling at school because she has coprolalia. And for the first 2 weeks I was working with her, that was a really hard tic for her. And now she can manage it. So she doesn't have it anymore. So, and now it's not happening anymore, and she doesn't have to use her strategy for it anymore either because it's waned. It doesn't happen. But she knows that if it does come back, she has something she can use to manage it right off the bat.
Well, those strategies seem very good. It sounds like a great program.
Yeah.
Thank you.
You're welcome.
And we had one question that came up in the chat box, and that's from Sarah. And the question is there any role for a COTA to play in CBTI?
CBIT?
Pardon me.
Yeah, absolutely. Absolutely. So a COTA can learn how to do this just like an OT. I'm not sure about the evaluation part though. That's the only thing. So, but absolutely, I would love to have a COTA work with me if I could do the evaluations and have that individual help me with the treatments, interventions, because I could see so many more people if I could do that. So I think there absolutely is space for COTAs in this realm. It would be a great OT-OTA partnership. Are there any other questions? Okay, well, I think I'm supposed to remind you all to please complete your course assessment of this presentation. so that you can receive your continuing education certificates.
That is correct. Thank you so much,
All
Debbie.
right.
You all have a wonderful night.
Thank you.